Welcome back to the deep dive. Today we have a critical mission. We're going to try and turn one of the densest anatomical chapters, chapter 55, on the respiratory diaphragm and phrenic nerves, into a clear mental roadmap.
It's a big one. This single sheet of muscle does something like 2/3 of the work when you're just breathing normally.
Yeah.
It's completely integral to your core stability.
Okay, let's unpack this. We are focusing on just a remarkable piece of engineering. It's the single most crucial barrier separating, the chest cavity, the thorax, from everything in the abdomen below it.
Exactly.
And for anyone learning this, trying to picture its attachments, how it moves, its connections, it can feel impossible without a diagram right in front of you.
And that is the core challenge. We're talking about something that's fundamentally dynamic, not static. I mean, it's only about 2, maybe 4 millimeters thick.
That thin, wow.
That thin, yet it acts as the piston for ventilation. It's a key anchor for trunk support, and it's essential for maintaining abdominal pressure for things like continence. It's really the definition of form-meeting function.
So our deep dive today is really about building that mental model step by step.
Right. We need to get its unique asymmetrical shape. Then, how it anchors itself. The attachments. We need to talk about what gets to pass through the apertures. And critically, that vital motor connection, the famous C3-C5 supply, which creates some really important clinical relationships like referred pain.
Let's start with that shape then, that dynamic shape. When you picture the diaphragm, you shouldn't be thinking of a flat floor. It's more like a massive dome
The cupula.
with a convex, sort of bulging upper surface forming the floor of the thorax, and then a concave, hollowed-out lower surface that's the roof of the abdomen.
That dome shape is absolutely key, but the asymmetry is, I think, even more telling. If we imagine looking at someone after they've forced all their air out of forced expiration, the right dome is always higher. It sits right around the level of the fourth costal cartilage.
And the left side is lower.
The left dome is always a bit lower, yeah. Maybe one costal cartilage level down. And the reason for that is the huge liver sitting right underneath the right side. It just pushes that dome up.
Whereas the left side has the stomach and spleen, so there's a bit more give.
Exactly. It's a beautiful asymmetrical arrangement that's just based on the organs around it.
And what about its coverings? You mentioned it's not just bare muscle.
No, not at all. Think of it like a ceiling with different wallpaper above and below. On the top, the thoracic side, the parts touching the lungs are draped in diaphragmatic parietal pleura. But right in the middle,
Where the heart sits.
precisely, right there, the parietal serous pericardium, the sac around the heart, blends directly into that central part of the diaphragm. The heart is essentially resting right on it.
And on the bottom, the abdominal side.
If you flip it over, it's covered by diaphragmatic fascia, which is really just a continuation of the transversalis fascia, and then, of course, the parietal peritoneum that lines the whole abdominal cavity.
What's fascinating here is how its movement changes with posture. That's something you don't really think about from a textbook diagram.
Oh, movement is everything. Even with quiet breathing, the excursion is only about 1 to 2 centimeters.
That's it.
That's it.
Sure.
But take a deep, forced breath, and that range explodes to 5 to 7 centimeters. And here's the posture part. The diaphragm actually sits higher up when you're lying flat on your back, supine, compared to when you're standing up.
Because gravity and the abdominal contents are pushing up on it.
You got it. It makes it harder for the diaphragm to descend when you're lying down.
Which brings us to synergy. The sources really emphasize that this isn't just about moving air, it's coordinated with everything below it.
Absolutely. When the diaphragm descends during an inhale, that instantly jacks up the intra-abdominal pressure. And in response, the pelvic floor, the body's base, also has to descend slightly.
It's like a closed hydraulic system.
That's the perfect analogy. This synchronized pressure change is vital for supporting the trunk, stabilizing the spine, and maintaining continence when you do something that spikes pressure, like coughing or lifting weights.
Okay, let's shift gears to the architectural blueprint. It seems to be defined by 2 main components. The peripheral muscle part, which does the work, and then this strong, thin central part.
The central tendon, yes. It's the linchpin. It's classically described as trifoliate,
Trifoliate.
meaning it has 3 leaf-like extensions, or folia, a middle one, a right and a left, and they curve backwards in a sort of V shape. And because this tendon is relatively anterior, the muscle fibers coming from the back of the body, from the lumbar region, have to be much, much longer than the ones at the front.
So let's detail those muscular origins. We have a sternal part, a costal part, and then the really complex lumbar part.
The sternal part is tiny. Sometimes it's not even there congenitally. It just comes off the back of the xiphoid process. The costal part is the big one, the broadest part, coming from the inner surfaces of the lower 6 ribs and their cartilages.
And it connects with another muscle there, right?
It does. It interdigitates with the transversus abdominis muscle, creating this continuous sheet.
Now, the lumbar part, this is where it gets complicated. It uses the vertebrae as an anchor, but also these arches, the arcuate ligaments.
This is where you really have to visualize that posterior wall. The diaphragm needs strong anchors back there. So you have to take 2 arcuate ligaments, forming arches over muscles that are already there. First, the medial arcuate ligament.
Okay.
That one arches over the top of the psoas major muscle. It connects the side of a lumbar vertebra to the transverse process of L1.
And the other one, the lateral one.
The lateral arcuate ligament arches over the quadratus lumborum muscle. It runs from that same L1 transverse process out to the bottom of the 12th rib. They're really just thickened fascia that give the muscle something strong to pull against.
And then we have the crura, the tendinous columns.
The crura are like the feet of the diaphragm. The right crus is the powerhouse. It's broader, longer, coming from vertebrae L1, L2, and L3. The left crus is a bit shorter, just from L1 and L2. And they meet in the middle, in front of the aorta, to form the median arcuate ligament.
That's a dense structure, but knowing where the muscle stops seems just as important, especially for hernias. The design flaws, as you called them.
Design flaws is a great way to think about it. You have 2 main weak spots. Up front, between the sternal and costal parts, you find the sternocostal triangles. The triangles are more Morgagni.
And things can pass through there.
They do. The superior epigastric vessels run right through them. But it's also a site for retrosternal hernias, where abdominal contents can sneak up behind the sternum.
And then there's a big one, the posterolateral gap.
That's the most significant one. The lumbocostal triangle, or the triangle of Bogdalek. It's a major developmental defect posterolaterally, where the muscle fibers just didn't quite meet up during development.
So it's just covered by thin layers.
Just thin fascia, pleura, and peritoneum. It's the most common route for serious congenital diaphragmatic hernias in newborns.
Let's talk logistics then. How does everything else get through? There are 3 huge gateways for structures passing between the thorax and the abdomen.
3 critical gateways, yes. The aortic, the esophageal, and the cavoforamen. And to picture them, just remember the sequence from top to bottom.
Okay, top to bottom.
The cavoforamen is the highest up. Then the esophageal hiatus is below that, and the aortic hiatus is the lowest and most posterior of the 3.
Let's start at the bottom then, with the aortic hiatus around T12.
The crucial thing to remember about the aortic hiatus is that it is osteoaponeurotic. It's bordered by bone, the vertebral column, and the tendinous median arcuate ligament.
So what does this all mean functionally?
It means the aorta passes behind the diaphragm's actual contracting muscle. So when you take a deep breath and the diaphragm contracts hard, the blood flow in the aorta is not affected at all. It's in a stable, protected tunnel. The thoracic duct also passes through there.
Okay, here's where it gets really interesting. Moving up to the esophageal hiatus, around T11, this one is totally different.
Completely different. This one is a muscular tunnel. It's about 2.5 centimeters long. It lets the esophagus through, of course, but also the vagal trunks. And the key detail is that this tunnel is formed by muscle fibers from the stronger right crus, which loop around the esophagus.
That loop sounds like it has a purpose.
Oh, it's the body's natural anti-reflux mechanism. That muscular sling acts like a physiological sphincter. When you inhale, the diaphragm contracts, those muscle fibers tighten around the esophagus, and it pinches it shut, preventing stomach acid from coming back up.
Brilliant. And finally, the highest one, the cavaloforamen, way up in the central tendon itself.
And this one is unique again. It's purely aponeurotic in the tendon, and it's kind of quadrilateral in shape. It transmits the inferior vena cava, the body's biggest vein.
And the vein actually sticks to it, right?
It adheres strongly to the margins, and it also transmits branches of the right phrenic nerve.
That adhesion seems like a masterstroke of design.
It really is.
Yeah.
Because the foramen is in the central tendon, when you inhale and the diaphragm contracts, the tendon gets pulled flat and tense. This actually pulls the foramen open. It dilates it.
At the same time, that abdominal pressure is increasing.
Exactly. The combination of the hole getting bigger and the pressure pushing from below acts like a powerful suction pump, dramatically increasing venous blood return to the heart. It's incredible.
Let's move to the network, the vascular supply, and maybe most critically, the innervation. I see the blood supply is pretty extensive.
It is. But the 2 big players, especially on the abdominal side, are the right and left inferior phrenic arteries, the IPAs. They usually come right off the celiac trunk or the aorta and supply that whole bottom surface.
And on the venous side, there's a small detail that's actually a huge deal for surgeons.
A huge deal. The right inferior phrenic vein. It usually drains into the IVC at a very specific spot, just above where the main hepatic veins from the liver join in. For a surgeon mobilizing the liver for a resection, finding that vein is a critical anatomical waypoint. It tells them exactly where they are relative to the major vessels they need to control.
Okay, but what's fascinating here is, for such a complex muscle, the motor control is just shockingly simple.
It really is. It's all down to the phrenic nerve, C3, C4, and C5. There's a reason for the rhyme. C3, 4, 5 keeps the diaphragm alive.
Yeah.
These nerves provide the sole motor supply.
The sole supply.
The only one. They also provide sensory innervation to the central part of the diaphragm. The very periphery gets some sensation from the lower intercostal nerves, but the motor control is all phrenic.
And the paths they take aren't identical, which makes a difference in surgery.
They're not. The right phrenic nerve passes through the central tendon, either through the cavaliformin or right next to it. But the left phrenic nerve, it takes a more vulnerable route. It passes right through the muscular part of the diaphragm, more anteriorly. This puts it at a greater risk of injury during cardiac surgery in the chest.
Let's tie this all together with the clinical correlations, starting with what happens if that critical C3, C5 supply gets damaged.
Well, if you cut the phrenic nerve, say, in the neck, that entire half of the diaphragm is paralyzed. It just atrophies. On an X-ray, you'll often see that hemodiaphragm is raised up higher than it should be.
And it moves wrong, too.
That's the definitive sign paradoxical movement. During inspiration, instead of moving down, the paralyzed side gets sucked up into the thorax by the negative pressure created by the good side. It moves the complete opposite way.
And what about that classic pain presentation? Why does irritation under your diaphragm give you a sharp pain in your shoulder?
Any irritation of the diaphragm pleurisy, a subphrenic abscess, even just air in the abdomen after surgery, pneumoperitoneum, is frequently felt right at the tip of the shoulder.
So what does this all mean? How does that connection work?
It's a textbook example of referred pain. It comes right back to those shared nerve roots. C3, C4, and C5 are the spinal nerve roots for the phrenic nerve, but they're also the roots for the supraclavicular nerves, which supply the skin over your shoulder. The brain gets this pain signal from the diaphragm via C3, C5, but it misinterprets it as coming from the shoulder, an area it's more used to hearing from.
Amazing. And finally, hiatus hernias. That comes back to that muscular esophageal tunnel we talked about.
Exactly. These are incredibly common. The most frequent is the sliding hernia, a type I. That's where the junction between the stomach and esophagus just slides up into the chest.
And because that muscular sling is compromised, that leads to reflux.
Almost always. It's the classic cause of GER. The other main type is the para-oesophageal hernia. That's where a part of the stomach herniates up next to the esophagus, but the junction itself might stay put. Reflux is less common, but the risk of the herniated stomach getting strangulated is much higher, so they can be more urgent.
That was an incredibly detailed walkthrough. So to quickly recap, the diaphragm is this crucial asymmetrical trifoliate muscle sheet. It's powered exclusively by the C3, C5 phrenic nerves. It's anchored by the crura and arcuate ligaments, and it's pierced by three key gateways, from the IVC at the top down to the muscular sling for the esophagus, and finally the aorta, which passes safely behind it all.
And here's a final thought on that. We focus so much on the diaphragm's contraction, but its function relies just as much on the abdominal wall being able to relax and expand. I mean, if your abdominal wall were suddenly made rigid like a steel plate, inspiration would be physically impossible.
The diaphragm would have nowhere to go.
Nowhere to descend into. It really highlights that proper breathing requires just as much active relaxation of the abs as it does active contraction of the diaphragm. It's a true partnership.
A perfect demonstration of the body's mandatory synergy. Thank you for joining us for this deep dive. We really hope this roadmap helps you visualize and master this absolutely essential structure.